Welcome to part 2. Like we said, for LVH, this was one of the criteria. Apart from that, if you look at V5, V6, the R wave solely is going to be more than 26 mm. That is also one criteria. Plus, I want you to look at all the precordial leads, and in that, whatever is the largest R wave and the deepest S wave, together, if they are more than 45 mm, that is also another criteria. Like there was an RV strain in RVH, you'll also see LV strain in LVH. But the right ventricle was anteriorly, and the left ventricle is lateral. So we're done with this. I also promised I'd talk about axis deviation, so here we go. Niche we have AVF, it's the foot lead. Then we have here which is 0 degrees, but this is known as lead 1. Lead 1 is here, we'll have lead 2 over here, and we'll have lead 3 over here. So imagine the right arm where we have AVR, left may we have AVL. You can see clearly lateral leads, 2, 3 AVF are inferior leads. This is the right side of the heart. Trick for the degrees, this is 0 degrees. Your foot is perpendicular to the ground, so we have plus 90 here. So this is minus 90, 180, and minus 30, minus 150. Now there are two methods for axis interpretation. Is when you are looking only at 1 and AVF. Only be looking at the QRS. If it is positive in both leads, that is a normal axis. Now if it is positive in lead 1 and negative in AVF, positive, negative, means it is going towards the left. Means there could be a left axis. If you have negative and positive, that means it is going towards the right. So a right axis deviation. If both are negative, that may indicate an extreme axis deviation, which would lie somewhere here. Next method is to just look at the limb lead. The QRS will be small in all the leads, except for any two leads. So if suppose it is tall in lead 3 and EVF, that automatically indicates that it is somewhere here, and that means it's a right axis deviation. Suppose I say it's tall in AVL, that may mean a left axis deviation, and so on and so forth. A little cheat sheet for you. If both are pointing away from each other, that is left axis. Going towards each other, that is right axis. If both are negative, that is extreme axis. And if both were upward, that is normal. Coming to abnormal atrial rhythms, we have atrial fibrillation first. Look at this strip. You have irregular pattern. There is no distinct P wave here. If you see how the atria are contracting, they've just gone bonkers basically. The heart rate of the atria, if you look at it, is more than 300 approximately. So atria are not properly contracting here. They are just fibrillating like this. Therefore, the stasis in the atria and giving rise to thromboembolism, which could lead to strokes. You calculate heart rate in this, because as you can see, it's not regular. Just take one hypothetical minute wherein you have 30 large boxes in 1 minute. And in those 60 seconds, count the total number of QRS complexes. Suppose I get 13 QRS complexes in 60 seconds. That means 13 into 10 gives us 130 beats per minute is the heart rate in this case of atrial fibrillation. Supposedly, I gave this patient certain drugs and the heart rate has come down to 110 or less than that beats per minute. This is what I will call rate-controlled atrial fibrillation. Let's talk about atrial flutter. A sawtooth pattern, which represent the flutter waves. They could be upright in V1 and inverted in 2-3 AVF. In flutter, not every atrial flutter reaches the ventricle. For example, here it is a 3:1 AV conduction block. That means after 3 atrial flutters, there is 1 conduction to the ventricle. Supposing you have an atrial rate of 300 BPM, so in a 3:1 block, every 300 beats are going to give 100 ventricular beats, which is going to come out as your heart rate. So 100 BPM. Normally the QRS is normal, less than 120 milliseconds, which is a narrow complex tachycardia. Continuing with more rhythms in part 3.